All right, everyone, we're going to go ahead and get started. As you know, I'm Melissa Wilson. I have this series of webinars called From the Clinic to Living Room. And tonight we have a wonderful special guest, Dr. Jason Luke, who is the Director of Immunotherapeutics at Hillman Cancer Center at the University of Pittsburgh. We're going to talk tonight about the new standard of care for stage II and C melanoma. So Dr. Luke, I wanted to just thank you so much for joining us tonight. I know that this is a hot topic. You were the primary principal investigator on this trial that prompted the approval. So thank you again for joining us.
Well, thanks so much for the opportunity. I always love to interact with the folks who actually need the info. And so I really love to participate.
This is great. And I think that, hopefully we'll get a lot of education for patients out tonight. But before we kind of delve into the meat and potatoes, I just, stage II melanoma, we kind of follow these patients. They have deep tumors, especially in the 2B, 2C category. And because we know that we use adjuvant therapy for stage III, if you could just speak to our participants tonight about why, what prompted the need for this trial in stage II patients.
Absolutely. And so, I think that that's actually the perfect way to start this conversation because as I think most people listening will realize that the treatment of melanoma has changed dramatically in the last 10 to 15 years, such that before about 10 years ago, the treatment options, even for advanced melanoma, were quite limited. Mm-hmm. And so there was an emphasis around trying to prevent patients from having the melanoma come back. And during that time, drugs like a drug called interferon, which some of you probably haven't even heard of, was given to patients with stage II melanoma because it was thought they were at high risk to have the melanoma come back. But during that interval 10 years, a bunch of new treatments have been developed. And you've probably heard of them like immunotherapies. And usually what we mean by that are PD-1 blocking antibodies, which might be too complicated, but they have names like pembrolizumab or KEYTRUDA and nivolumab or Opdivo, as well as treatments that target the BRAF oncogene. And so those are targeted therapies like sometimes. And the reason I'm explaining that was it became standard to give those drugs first to patients with advanced melanoma that had spread. But then it became standard to give those treatments to patients who had involvement of their lymph nodes during surgery. But what was forgotten about during that period was that those patients who had deep primary lesions on their skin, in other words, the melanoma grew deep down into the skin, actually still were at very high risk, but for various regulatory and logistical reasons, they were not included in the initial clinical trials. Right. So dating back to about 2015, actually, we recognized that problem and said, hey, these patients are at high risk also. We should design a clinical trial to show that these new immunotherapies that we have work for these patients also. And that really was the rationale for the development of KEYNOTE-716, which you'll hear us reference. That's the clinical trial we're talking about. And I'm very excited to explain what these data, what were and what they mean, I think, for people who are facing the diagnosis of a deep melanoma.
True, because, what we want to, and what patients really want to know is how can this help me? So what do the results of this KEYNOTE-716 trial mean for me in terms of reducing my risk of reoccurrence?
Yeah. So again, building on this observation that actually patients who have deep primary melanomas, and just quickly, just for numbers so you've heard them, that means a patient who has a melanoma of at least 2 millimeters in depth with a feature we call ulceration, or a melanoma that's at least 4 millimeters in depth with or without ulceration. And so when you get your pathology report or when you talk to your doctor, these are terms that you might hear, and these emphasize a high-risk state. And so what we know is people with these features in their melanoma, even if the lymph nodes are not involved, have the same risk of melanoma coming back and people potentially dying of melanoma as the people who have the lymph nodes.
Right.
And what the data from this clinical trial now mean is it's reasonable to consider taking the same treatment, the immunotherapy, that we would give for people with the lymph nodes for the people who have the deep primaries. And I can go into the details of the clinical trial numbers, but I think I'll wait to see whether or not that's really kind of the, what we're interested in.
Well, I think one of the things that, patients always ask is, how much will this reduce my risk? So if I'm looking at, I have a 30 to 35% risk of reoccurrence, what does doing this adjuvant therapy do for that risk?
Absolutely. So that's a great question. And the answer to this is sort of. But I'll explain what that means, sort of, okay? Which is to say that we know from the lymph node positive patients where we've given this immunotherapy for a long time that the risk of melanoma coming back is reduced in that setting by about half. Mm-hmm. In the first data disclosure, the first time we analyzed the clinical trial for patients with stage II melanoma, we saw that initially there was a 35% reduction in the risk of melanoma coming back. But when we analyzed the data again 6 months later, that had gone to 39%. So our full expectation is that over time, when we take account of everybody who was in the clinical trial, because realize there were almost 1,000 patients in the clinical trial, and for most of them, nothing has happened yet. We think eventually taking this treatment after surgery will reduce the risk of the melanoma coming back by about 40 to 50%. That's our expectation based on our prior experience.
Right. And you want to look at the long game too. We're not looking at recurrence just in the short 1 to 2 years. We're looking at, 10-year survival overall, which is super important. Do you, based upon this, data that was presented, I know there's been a lot of discussions that I've heard just in sitting in rooms with oncologists about, looking at the side effect profile in stage II patients versus, the benefit of, the reduction in risk. So would you want to speak to that in terms of what your opinion in that is?
Absolutely. And this is where the sort of comment that I made kind of starts to come in. Okay. So most people are used to going to the doctor and being told what treatment to take. And it's pretty straightforward, take some Tylenol. Okay. Fix a headache. Well, in cancer treatment, even with our immunotherapies, which tend to cause a lot less side effects than chemotherapy, because in melanoma, we don't really give chemotherapy, there still can be some side effects. And some of those side effects in rare people can be pretty extreme. And so when we think about giving a treatment to reduce the possibility of the melanoma coming back, we have to wait. How scared are we of melanoma coming back versus how much side effects are we willing to think about, since we don't actually know whether or not the melanoma is going to come back?
Sure.
Okay. And so in that regard, there's a small but real population of about 10 to 20% of patients who can get thyroid problems that they're probably going to have to take thyroid medicine the rest of their life. And that's standard with these immunotherapies. That's not specific to this trial. That's standard. And similarly, it's standard with these immunotherapies for all the different ways we give them, for lung cancer, for melanoma, for kidney cancer, for all of them, that there's a rare, but maybe 5% of patients who can get severe autoimmunity. And if you've heard of things like lupus and rheumatoid arthritis, it's sort of like that, where people can have the development of severe side effects that, can be lifelong in management. And so then we really have to think, how risky is it the melanoma is going to come back versus how risky is it we're going to get these side effects? And this is where discussion of the actual exact numbers is really important when you talk with your doctor about how you feel about melanoma coming back. Because I've certainly seen patients who said, "Doc, hit me with the house. I don't care what happens. Don't let the cancer come back." Certainly. And I have other people who come in and say, I'm really scared of side effects and I don't know, and this and that. And so the answer to the question is, it's to each their own. And we want to make sure that people understand all the aspects of this, the risk, both of the melanoma and of the side effects, so that you can choose what you think is right for you. And we, the medical professionals, can support you in making that decision.
Right. And ultimately, it's an individualized decision. And we always try to remind our patients, we're in this together. This is not just me telling you what to do. We need to have a discussion about it. So I think that that's one really important thing for participants to take home to their medical oncologist, really moving forward. I guess one of the questions that I had ahead of time was, given that this FDA approval just happened, if someone had gotten diagnosed in June, is it worth it for them to consider doing this adjuvant therapy now? Or really what, time frame does this become, something that's kind of that ship has sailed?
Yeah. So that's a really good question that actually comes up more than just this clinical trial. This kind of thing comes up a lot. And the answer is we don't really know the answer. Okay. So if you were diagnosed in the past year, it would not be outlandish to consider taking the treatment. Now, that being said, per the FDA label of the drug, it should be started within about 3 months of when you had your surgery. Now, is your risk really different in a year versus 3 months? That's where I said it gets gray. So this is not medical advice. Okay. So, but I would say that's you should go talk to your doctor about that. If you were diagnosed 5 years ago, then it doesn't really make any sense. But if it, you have to kind of adjudicate these things as they come, because just like you mentioned, this was a different conversation a year ago than it is right now.
Well, even 6 months ago in some places, that didn't have access to the clinical trial. So, I think, it's a relevant topic that I think is going to come up quite a bit in the, next month, and probably especially after this webinar hits the internet. And I think, determining what the best option for you is not a, straightforward answer at this point, I think. One of the things that also was brought up is, in this population of patients, and it's going to be a little hard to, I guess, answer is, in terms of incidence of toxicities or autoimmune toxicities, did we see more toxicities in the adjuvant setting in stage 2 patients versus stage 4? Like, are we looking at more risk of autoimmunity or pretty much the same across treatment groups?
That's a good question. So it's slightly complicated. The results in the current clinical trial that we're discussing for stage 2 melanoma for side effects looked very, very similar to what we saw for patients with stage 3 melanoma, which we consider it standard to give this treatment. Okay.
Right.
But the incidence of side effects for patients who are treated who have had their melanoma removed are ever so slightly higher than people who still have melanoma. And that's because we think if the cancer is still obviously in the body, that actually suppresses the immune system.
Right.
And that can lead to suppression of the side effects from the immunotherapy as well. So we kind of think that's bad. But the point is, in clinic, you do need to be cognizant that side effects are important. And I would even argue, though, they're even more important in a post-surgical trial where the possibility already exists that, you could be cured, and you're taking extra treatment to make sure that your risk is even lower. So I would say our tolerance of side effects is actually even less.
Sure.
But, I think, again, this is where the patient level decision, you have to decide for yourself as a person dealing with this, how you weight the risks that are, apparent here.
Okay. Just one more thing before we try to take some questions, because I have a feeling that's going to open Pandora's box a little bit. But given this recent development, are there other clinical trials that are looking at adjuvant therapy in this setting? You had mentioned targeted therapy. Are we looking at other potential options besides just the one that was, just approved?
Absolutely. So KEYNOTE-716, the clinical trial we're talking about, involved a drug called pembrolizumab, which many of you may know as KEYTRUDA. There's a very similar clinical trial called Checkmate-76K, who comes up with these names, of the drug nivolumab, which many of you will know as Opdivo. And again, most of you will know that in melanoma, the results from almost every clinical trial between pembrolizumab and nivolumab look almost the same. So we're fully expecting that the nivolumab Checkmate-76K will show the same results as KEYNOTE-716.
Right.
In addition to that, in Europe, they are planning a clinical trial to give BRAF inhibitors to BRAF mutant melanoma in stage 2 as well. But that clinical trial is still being designed and hasn't started yet.
Okay, excellent. So we do have a couple of questions that are coming in. So Susan wants to know if you could discuss if or how this study and outcome relate to mucosal melanoma. So, obviously we do a lot of our trials that involve cutaneous disease. Do we have any data in terms of mucosal patients?
So that's a real good question. Unfortunately, mucosal melanoma is a less common subtype of melanoma. And due to the incidence, it's hard to run clinical trials that are specific for that.
Sure.
So because of that, we generally speaking extrapolate from the data that we generate in cutaneous melanoma. So in stage 3 melanoma, we do treat patients with mucosal melanoma the same way and offer the adjuvant treatment. That's standard. So I think by extrapolation in stage 2, we would probably do something similar, albeit that we don't have the specific answer. The clinical trial didn't look specifically at that question, but generally in our clinical practice, we tend to kind of extrapolate over from one kind of melanoma to the other one, understanding that that's imperfect, but it's kind of the best way we have to go off of it.
Yeah, I think that makes good logical sense. Lauren would like to know, is it better to wait for disease to recur and then take a treatment, or to do adjuvant therapy? And I think this is a question that unfortunately comes up more often than not.
Absolutely. Laura, you should join our melanoma key opinion leader arguments that we have. So this is actually a very important question that we don't know the answer to. Should you take treatment right after surgery, or should you wait till melanoma comes back? And the answer is that we don't know the answer. There are some hints that waiting for treatment on average might be as good as taking it right after surgery. The problem with that logic from my perspective is that you as an individual are not the average. You as the patient are either going to have the melanoma come back or not. And if you have the melanoma come back, we don't know what's going to happen. Some patients have melanoma come back, and there's no question they get these same immunotherapies and they do very, very well. But some people have it come back and things don't go so well. And we won't dwell on that, but I think everybody here understands that. Otherwise, they wouldn't have joined, right?
Right.
And so I think this is where that risk tolerance comes in. What's more important, the possibility of having the melanoma come back, or the possibility you might get side effects from the treatment? And for each patient, that may be slightly different. So just to specifically answer the question, we don't know whether treatment now versus later is better. But I know that for me personally, and I'm not speaking for you, the patient, but for me personally, if I knew I could reduce the risk, I personally would want to do so. But you as an individual need to make that decision about risks and benefits.
One of the other things that is coming up a lot in this setting is patients that have Castle testing or have the molecular, genomic testing that suggests that their melanoma has a less of a chance of reoccurrence, but they're still 2B. So what do you say to that population of patients?
Oh, that life is complicated.
That Castle testing complicated everything.
I totally hear you. So what I'll say is that right now, based on gene expression tests, which is what the Castle test is, we have a suggestion that there's a higher level of risk. So in my practice, for patients who have a high risk Castle test, we do follow them more closely under the concern that the melanoma might come back and might have a higher chance than your average patient. But currently, we do not have evidence that supports the idea of giving these treatments to reduce that risk for patients that are outside of what we talked about. So for KEYNOTE-716, we talked about stage 2B and 2C. So I think you'd be talking about stage 1 or stage 2A, where that could be of relevance, right? And so that's a hard thing. Do we think the same treatment would probably work for those patients? Probably, but we don't know that. And so again, in that risk benefit consideration, we'd kind of be going with the risk, but really having no idea what the benefit is. So we don't really do that. Now, I will say that from the clinical trial KEYNOTE-716, we did attempt to collect that information where possible. And in the future, we do plan to analyze the data informed by the extent to which we have the Castle assay, as well as a number of other what we call biomarkers or molecular tests like DNA and RNA from the tumor to try to look and see if we can identify which patients benefit the most and which ones were less, And hopefully we'll be able to give you a better answer to that kind of question, maybe in a year or so.
Oh, that sounds good to me. Let's see. So we had an anonymous attendee. Let me see what this says. Well, I mean, they asked, does any of this research or data help understand or apply to patients with stage 4 melanoma? We already know that these drugs are approved in stage 4 melanoma, so they're already being used. I don't know who the anonymous attendee is, but I hope that.
Well, one comment there is that, stage 4 melanoma obviously is when it's spread in the body, and there's no question these same drugs are already standard. One thing that does come up is every once in a while, even though it spreads, we can cut it out.
Right.
And we know actually these drugs also reduce the risk in that setting of it coming back again. So in that regard, it's not that this trial changes that, but we did know that already. And if that's sort of the intent of the question, it's important to point that out.
Right. So adjuvant therapy for a metastatic resection,
that's right,
essentially. So another anonymous attendee asked, what do you tell patients about the research regarding diet and health when on immunotherapy?
Yes, absolutely.
This isn't exactly related to what we're talking about, but I thought it's a hot
great
topic.
Question.
We might as well handle it.
Yeah. So before I was fortunate enough to come to UPMC and work with Melissa and a lot of other people, I was at the University of Chicago, where we did one of the first studies to look at the association between which bacteria are in the body and the outcomes for patients who take immunotherapy, showing that in our analysis, there were certain bacteria that seemed to suggest better or worse outcomes with immunotherapy. And this is a field that's really in flux right now. And so I do not recommend necessarily that people run out and take a supplement like a probiotic or something else, because the field doesn't agree on which exactly bacteria are the most important or the worst. We have some hints, but not enough information to tell you, hey, run over to CVS and grab this thing. In fact, what we do know is that from a lot of patients, eating a high fiber diet does appear to associate with good outcomes to immunotherapy. But that should kind of be obvious, right? Eat your greens, have some good diet, get some exercise, don't be stressed out, get some sleep. These are all the normal things, right? So that shouldn't be a surprise. But I'll caution that in the same analysis of looking at the diet in terms of fiber, what some researchers recently identified was that those patients who actually did take probiotics over the counter, they actually did worse.
Right.
And the reason for that isn't really known, but a hypothesis that I've heard is that most of the over-the-counter probiotics have been developed for people with irritable bowel syndrome who have an overactive bowel. And they actually have the intention of suppressing the immune response. So if you take them, you actually could limit the ability of your body to have a response to the immunotherapy. So all of this taken said, I'm not a big proponent of supplements.
Right.
And so I'm not here to tell you can't take them, but there's not much evidence that they do much and they might hurt. So get your greens, get your sleep, get your exercise, and stick to that stuff. We know it works for everything, cardiovascular, cancer, everything.
So Sandra just wants to really quickly ask how KEYTRUDA is administered. I can handle that one. It's IV. It's an IV treatment. I know with Keynote 716, it was the 200 milligram dosing, correct?
Every 3 weeks.
Right. So in terms of following that FDA approval, we have people coming in asking for, the Q6 week treatment, the Q4 week treatment. We've been trying to stay with what was, found with the clinical trial. Are you deviating from that, seeing deviations from that with other oncologists, or is everyone pretty much sticking to what we know?
Yeah, what I would say to that is that the approval for the every 6 week pembrolizumab actually covers this indication as well. So it's reasonable to take every 3 weeks or every 6 weeks, and you just adjust the dose depending on how often you come.
Right.
I don't have a strong opinion about this. In my practice personally, I tend to use the 3 week for at least the first 3 months. And the reason for that is most of the side effects you're going to get are probably going to happen in that period. And I kind of want to see you more often to make sure you're okay. If you do really great and you get past that first 3 months, then the conversation about not coming so often, I think, is a little easier for me. But there are doctors that do it each way, and it's not right or wrong. It's FDA approved to do it both ways. This is why, your individual practice and your team is going to have an idea of how they do things, and it should line up with what you feel is good for you.
Exactly. Sheila kind of followed up with that to say, like, does it have to be 3 weeks exactly? We always tell our patients, if you're on vacation, you come back at week 4, we're still going to give you your treatment. It's okay.
Exactly.
There's
sometimes it snows. Sometimes your kids are at home. Like, we get it, right? It's COVID. Come on now.
Life happens. You have to be busy. Somebody actually asked, whoops, and I'm going to see it in the chat about NKTR214. I hope that you know what that is, because I do not.
Sure. That's Nectar 214, also known as bempegaldesleukin. So again, who comes up with these names, right? So bempegaldesleukin is a new drug that tries to take what we historically knew about a molecule called interleukin-2 and develop it in a new way. So there are clinical trials looking at a modified version of interleukin-2 called bempegaldesleukin, or NKTR214, combining it with immunotherapy. And there's a clinical trial ongoing for patients with cancer that has spread, melanoma that's spread, combining the drugs versus just giving the immunotherapy. There's also a clinical trial for patients who have involvement of lymph nodes after surgery for giving NKTR214 plus nivolumab or nivolumab alone. The comment says, any news? And the answer is not yet. And so we think that probably within the next year or two, there will be a lot of news. It'll be very interesting to see what those results look like. It's a very different kind of treatment than the other immunotherapies, but we're very excited based on the preliminary data that it might be a new drug that's going to be very useful to treat melanoma. But I'll caution that we have to wait and see.
Okay. We're going to end with one final question, that because we have lots of things that are very specific that we unfortunately can't answer live. But Lauren wants to know, is there a blood test or particular scan outside of surveillance CT scans that can predict who might recur after surgery? And then we will end there.
Very good question. And we really want to know the answer to this, and we're working on it really hard. We don't know the answer yet, but there are a number of groups working on this. And there are analysis of, in the blood, we can check for the DNA that came from the tumor. We think that might help us inform whether or not there's a risk that could come back. That's also going to be analyzed in the clinical trial KEYNOTE-716. But there are actually some vendors that have non-FDA approved tests that you can buy. The problem becomes is they're not validated vis-a-vis what we normally do in practice. So this is a space that I think you should watch closely, because I think will definitely evolve in the next, say, 2 to 5 years. But right now, the answer, formally speaking, is no, we don't have a test for that.
Exactly. Well, Dr. Luke, I really appreciate all of the information. You are a wonderful researcher. We're so blessed to have you at Hillman Cancer Center. Any take-home thoughts before I do a little announcement before we end the webinar?
Well, I would just emphasize quickly that Stage II melanoma is a high-risk melanoma. And historically, that's not the way the doctors have talked about it. But if you just look at the numbers in a book, it's obvious that that's true. And so these results from KEYNOTE-716 are very important just to prove that point, but secondarily to show that we do have a treatment that you can consider. And I want to final just by saying it's really up to you as the individual to understand what's the risk of melanoma coming back, what's the risk of side effects, and what does it mean for you to make that decision about what matters the most. And we want to empower you to make the decisions that are best for you and your family. And that can be very complicated. So take your time and make the decision you think is best for you.
That's perfect. Perfect way to end this little segment of our webinar. So again, thank you so much for joining us. And in the spirit of empowerment, I just wanted to really quickly also mention that today, the Melanoma 101 education website that's going to be on YouTube actually went live for me. So I actually started this year doing small little segments, 4 to 5 minutes of things that I couldn't fit into a 30-minute webinar. And so we have, what's a sentinel node? How does it work? How did I get melanoma in the first place? What sunscreen should I pick? Just kind of general education topics. So that website went live today. You can please subscribe. We're going to try to release a video once every other week. We want to look at lots of topics. really my job as a physician assistant in this, team that we have going on is to educate and empower patients. So hopefully, through education, we can get lots and lots of very educated, intelligent participants as patients in our clinical practice. So I'm going to link the website where that can be found in the chat, and that's it.
Smash the like.
Yeah, hit the like button, subscribe, so that, we want to get everyone educated. But I really appreciate all of your help, Dr. Luke, and I'll see you around.
All right. Thanks so much.
Thank you.